Begin. Uptake and distribution of anesthetic gases is virtually incomprehensible. That's what Dan Lawson wrote in a Gas Man review many years ago. Pharmacokinetics is important. Pharmacokinetics explains what goes on from vaporizer to brain. It's crucial to clinical practice, and it's an anesthesiology core competency. The American Board of Anesthesiologists lists it as one of the things that we need to all understand. That's why I wrote Gas Man. It's a structure behavior model that shows this. The model looks like this. The top half shows the locations of interest, termed compartments. We have delivered, breathing circuit, the alveoli, arterial blood, vessel-rich tissue group, muscle, fat, and venous blood. They're all across the top panel. We look at the agent level. They're depicted in these compartments. We are looking at the tension or partial pressure of anesthetic in these compartments, and they equalize over time. Concentrations don't equalize, they equilibrate, but partial pressure or tension equalizes. We have the agent flows along the bottom, from fresh gas flow, alveolar ventilation, and cardiac output. They are the flows that link the compartments with each other. Those flows conduct as we show here. An anesthetic goes from the delivered concentration with delivered tension to inspired tension, to alveolar tension, to arterial tension, and then to the brain in the vessel-rich group, to muscle, to fat, and then into venous blood. The confusing part is that the anesthetic then comes from the venous blood back to the patient's alveoli. And from the alveoli, it's exhaled back into the breathing circuit, and sometimes it's re-inhaled again with rebreathing, something we won't talk about very much here. We're talking about the kinetics themselves. We also have the timing and the agent use. We have the amount of time that the simulation has been going on, or the amount of time that the simulation is simulating. We have the uptake of the drug either in dollars or in liters or milliliters of liquid from the bottle, and the quantity delivered, again, in dollars, liters, or milliliters from the bottle. We can change the price before or after giving anesthesia, because that allows us to compare prices over time if the price of these drugs should change. The unit of measure that we use is the partial pressure or tension of anesthetic. In Gas Man, this anesthetic is shown on the picture and the graph, and they are equal to each other, partial pressure or tension. They are really the same thing. It applies to the gas locations of delivered, inspired, and expired, as well as the dissolved locations, arterial blood, vessel-rich groups, muscle, fat, and venous blood. When we think about partial pressure, we talk about it as a pressure in the following sense. Isoflurane being administered in 1% concentration is being delivered at a partial pressure of 1% of 1 atmosphere, 1% of 760 millimeters of mercury, or 7.6 millimeters of mercury. We don't talk about it that way. We commonly call it 1%, but we mean a partial pressure of 1%. It is that 1% that will equalize all over the body if the patient were to breathe this drug for an infinite length of time. End-tidal anesthetic concentration is measured in clinical practice in most countries. End-tidal agent concentration is equal to the end-tidal agent partial pressure or tension. End-tidal is measured at the end of exhalation just before the next inhalation. And the end-tidal tension is approximately equal to arterial tension, but end-tidal differs from arterial due to two phenomena which are not addressed during this talk, and they are dead space and shunt. The Gasman model itself appears to be correct. That is, when we look at wash in during induction and wash out during emergence, what we see is the following. During the first 15 minutes of anesthesia, the end tidal values fairly closely match that which Gasman predicts. And if we go out for another 360 minutes or 6 hours, it's matching very well throughout that entire time. At the end of an anesthetic of duration of a minute, of an hour and a half, or 2 hours, or these various lengths of time, what we see at the end of those durations of anesthesia, Gasman again predicts the end tidal level over time during emergence. The Gasman model errors are less than 10%, as has been studied recently by Dr. Ravi Shankar and his group in India. When we look at the red line for Gasman and the bars for the difference between the measured value and the Gasman value, they differ by no more than 0.05%, which is the resolution of the gas monitor. Let's see how to use Gasman. I'm going to move to the Gasman model itself. I'm going to run Gasman. I will start a new simulation, and we see we have 3 panels: the control panel, the picture panel, and the graph panel. In this control panel, the weight of 70 kilograms has been chosen, and it could be anywhere from 0.05 kilograms to 500 kilograms, thereby being useful for animals as well as humans. The circuit is semi-closed, closed, or ideal. The ideal circuit is one that has no rebreathing when the fresh gas flow is greater than the patient's minute ventilation. The speed is set to anywhere as slow as real time and as fast as possible, where many hours are calculated within 1 second. The special features of disable uptake, disable return, and vapor, I'm not going to discuss here. They are fine points of kinetics that are worth learning, but not this time. The Gasman picture is just as I showed before. And the Gasman graph depicts what has happened, and I can drag that tab over here and hold it next, and therefore be ready to show what goes on during an anesthetic. In this case, I've chosen a semi-closed circuit. And as we begin the anesthetic and turn up the vaporizer, we see inspired rise and alveolar rise and vessel-rich group rise. And all of this has happened over the first 5 minutes, which will extend out for a longer period of time, and continue this anesthetic, being smart enough to turn down our vaporizer, to hold the patient at approximately the dotted line of 1 Mach in the vessel-rich group. That's an example of a very simple, straightforward simulation with Gasman. And for the remainder of this talk, I'll use snapshots that I've taken of that screen. During the question and answer session, we can certainly explore this further. So we will begin with the alveolar tension curve. It is the response in the alveoli to a step change in the inspired concentration. Inspired suddenly goes up and is held constant, and we look at what happens to alveolar. What we see is there's an initial rise, a plateau in the curve that disappears into a curve going up. Let me simulate that here for a moment. As we look at the 0 cardiac output example, let me close what we had before. The 0 cardiac output example is where the patient's cardiac output doesn't exist. Do not do this in the operating room. We do this only in simulation. We have 0 cardiac output, and we're looking at the alveolar tension rise over time. What we see is a very simple curve. a curve that goes up rapidly at first and slowly thereafter. This is an exponential curve. It is the wash-in of drug into the patient's lungs if no cardiac output were taking it away, or if the drug had a zero solubility and was not taken away. We then can look at the next simulation, which will be for isoflurane looking at the plateau height. You'll see what I mean by that in a moment. So isoflurane, again, in an open circuit, we're going to look at a picture and we're going to watch it rise and stop going up. If we look at the graph of this, it has risen and failed to rise any further. The reason for that is that we have disabled the venous return from coming back to the patient's lungs, so we can identify what would happen if that weren't there. You'll see why we did that in a moment. And I'm going to do another simulation now, and I'll do that of sevoflurane. And we'll run that simulation. Rising rapidly and now rising more slowly. The graph looks like this, and it's a very similar graph to the other one. What we'll do now is an overlay of these graphs that we've done so far. This is the overlay symbol. And we now see this was lung wash-in in the absence of uptake by any drug. This is now isoflurane with the plateau height, and this is the sevoflurane with its plateau height. Sevoflurane is less soluble than isoflurane, therefore the alveolar tension rises to a slightly greater height. Less and less soluble drugs will be higher and higher at this point. I'm now going to simulate what happens when we, in fact, have sevoflurane or isoflurane with venous return, but I'll do that by moving on to pictures that we have there already. In those pictures, we have the initial rise, we have the alveolar plateau, and then we have venous return, allowing that anesthetic level to rise slowly over time as the anesthetic comes back to the patient's lungs. If we look at the impact of changing ventilation, bringing drug into the patient's lungs faster, here's what we see. I've started out here with the cardiac output and alveolar ventilation being equal. We've got this initial curve with this level of plateau. We then increase the patient's alveolar ventilation and the alveolar tension rises. We increase cardiac output and the alveolar tension falls. They're back to the same height they were before because these two are in the same ratio. If we then turn ventilation and cardiac output down again at the same ratio to each other, we find that the alveolar tension curve plateau is at the same height. That is, what we've seen is ventilation in is balanced against cardiac output out, and that determines the alveolar plateau height. If we then look at the plateau heights for ether, isoflurane, sevoflurane, desflurane, and helium, or rather xenon, very insoluble substance, we get these curves built, and these are the plateau heights for those various drugs. That's just being impacted by the cardiac output and ventilation and no venous return yet occurring. If we then allow the venous return to come, we'll see something different in a moment. First, let's look at what happens if we simply increase ventilation step by step with a constant cardiac output. The alveolar tension plateau rises and rises and rises because ventilation has driven more drug into the patient's lungs. On the other hand, if we have a high cardiac output and lower that cardiac output, the lower the cardiac output gets, the higher the alveolar plateau gets. This is that interaction between alveolar ventilation and cardiac output. If we now plot the graph of the complete alveolar tension curve, that is, including venous return for each of our anesthetic agents, we see the curve looks like this for ether, isoflurane, sevoflurane, desflurane, and xenon. These are the curves that we have seen in textbooks that describe what's called the alveolar tension curve. So we've been looking at the alveolar in response to a step change in the delivered or inspired concentration. But as anesthesia care providers, we're not simply setting the vapor somewhere and watch what happens to the alveolar concentration. We're focusing on our measure of alveolar, which is the end tidal concentration, and we're trying to keep that end tidal concentration where we want it to be. It may be constant, or we may want to change it. In any case, when we're looking at that alveolar tension curve with this shape, it is the alveolar over or divided by the delivered concentration. If instead of that, in Gasman, we want to show the delivered over the alveolar concentration by pressing those buttons, we actually have this curve generated all by itself. This is the alveolar tension required to keep This is the delivered tension required to keep alveolar constant over time. This is exactly what Professor Eager showed in the original 1963 article on MAC and how we achieve it and how we maintain it. It goes back to the history of what we know about kinetics, but here we can do it with a very simple click. So this is the delivered concentration over time to achieve an alveolar of the dotted line, which in this case was 1 MAC. So how do we in real life keep anesthetic depth constant? We continually lower the delivered concentration, which continually lowers the inspired. And then we do that in such a way that we hold the expired concentration constant. Our breathing circuit messes up our ability to control inspired precisely, but we're measuring inspired and we're measuring expired, so we can achieve this just fine. But we've got to work at it, look continuously, and adjust as needed. I want to look for a moment at the relationship between induction and emergence of anesthesia. The interesting thing about our inhaled agents is we can really measure them, and we can measure them all the time. And we can have certain conjectures of what would happen in certain situations. If we look at the curve of the alveolar tension curves going up and then ask the question, what will wake up look like? The answer is wake up from an infinite length anesthetic will be exactly the curve we had on induction, but it will be flipped upside down. It will be exactly the opposite. These were the alveolar over delivered curves, and the wake up from an infinite length anesthetic would look like that. This is literally the flip over of those curves, demonstrating that this is what would happen. Now, we can't simulate Gasman after an infinite length anesthetic, but we can do some very long ones, and that allows us to verify this and actually do those simulations. With inhaled drugs, we have the same measures that we use for intravenous drugs, and that's we might look at the context-sensitive half time. Well, context-sensitive means here the context was an infinite length anesthetic. The half time is the amount of time it takes the plasma level to get to half of what it was when we started reducing the drug level. So here, our inhaled anesthetic agents, we see that the half time of these drugs is in the neighborhood of 2 or 3 or 4 or 5 minutes. This is much faster than any intravenous anesthetic we've got. And that's the power of our inhaled drugs. They really are that fast in getting levels down, and their half time is incredibly short compared to other drugs. But it isn't the half time we care about for waking a patient up. We want to get it down by 67%. That is, we want to get down to 1/3 of MAC. So here's a line that I've drawn at 1/3 of MAC. And what we see is this is the amount of time it takes to reach that level for the 4 drugs I've depicted here. Isoflurane takes about 12 minutes, sevoflurane about 4 minutes, desflurane about 3 minutes, and xenon would be about 2 minutes. This is getting down to 33%. It's about the time that the patient will open his or her eyes. If we want the patient more awake than this, we might want to look at how long it takes to get down by 80%. In that case, all of a sudden we get this tremendous discrepancy of washout times. We get that because of the shape of these curves. As they get flatter and flatter, it means it takes longer and longer for some small degree of fall in the level. So we see that isoflurane is somewhere beyond 30 minutes. Sevoflurane is about 10, desflurane about 4, and xenon would be 3. Now, xenon is not yet an approved anesthetic, and I should have said that before, but it is an important drug to think about because it does have certain properties of anesthesia. Someday we will have it, and it's a good example of a very insoluble drug. We also could use nitrous oxide on those same figures. Well, Eager and Schaefer in 2005 used Gassman to study the context-sensitive decrement times that could be simulated and would allow prediction of wake-up times from various anesthetics. And what they found was if you give an anesthetic of duration up to 300 minutes here, and you give it for that long and you look for the 80% reduction, this is how many minutes it takes for the patient to reach that level. If we take it to a greater degree of reduction, that is an 88% reduction, isoflurane all of a sudden takes much, much longer. If we look for a 90% reduction, sevoflurane is starting to rise on its wake-up time or its resolution time. If we look at a reduction to 92%, again, sevoflurane and isoflurane is incredibly long amount of time. And if we finally look at a 95% decrement, desflurane finally starts to get a little bit long. That is as long as 50 minutes to get down to 5% of the level of anesthesia we had during the course of the surgical procedure. Now, patients don't wake up when the end tidal crosses MAC awake. I'm sure those of you who are astute clinicians have seen that over and over again. You think the patient's going to be awake because you're at 1/3 of MAC, but it really isn't that at all. The patient wakes up not when the end tidal reaches MAC awake, but rather when the brain reaches MAC awake. If we look at that in an operating room, here we turned off the agent at this point, and approximately 3 minutes later, that's when the BIS or whatever other monitor we might have been using starts to rise. And very shortly thereafter, the patient opens his or her eyes and responds to command. The brain delay after these end tidal changes is about 2 or 3 minutes. And if we look at the trend graph, we see that, as I just showed you before. There are several solubilities that we see of interest. At the beginning, we saw that the alveolar plateau is varying over a large range and that impacts the height of that alveolar tension curve. And in fact, it's 1,000 to 1 if we go across from nitrogen to ether. Ether is 1,000 times more soluble than nitrogen, and that's a lot. If we look at the solubility and the brain impact, we're looking at the brain blood solubility and a time constant that arrives therefrom. That is, blood gas solubilities were here, but brain blood solubilities are here. And they vary only by approximately a factor of 3 over the entire range of all of these, and they're all in the neighborhood of a time constant of 3 minutes. They're almost all identical. So all of our drugs yield a wake-up time of approximately 3 minutes from when end tidal has crossed MAC awake. And the gas man simulates brain delay during emergence, just as it does simulate brain delay during induction. Let's look at one of those brain delays during induction to get an idea of how that works. I'll close the simulations we did before. I'll do a new simulation. It will be sevoflurane in a semi-closed circuit in a 70 kilogram patient. We will turn the vaporizer up to, let's turn it up to 7%. And now I'm typing in the number of 7 to get it there immediately. And what we're going to look at is a graph of the time course of anesthetization. What I've done is I've hit the pause button when I saw alveolar reach 1 MAC. That occurred, we can see over here, is somewhere between 1 and 2 minutes. And if we click the cursor here, we can see it was 1 minute and 36 seconds. So if we then say, I think the patient's asleep, the end tidal value is 1 MAC, the patient would say, but my brain is only at 0.4%. I'm nowhere near awake. You really want to get me up to at least 1/3 of MAC, maybe 2/3 of MAC, or maybe a full MAC before we start doing anything significant. And in order to get to that, we will continue this anesthetic until we see the vessel-rich group get there. And it looks like that was just about 3 minutes of delay from when that end tidal reached to when the brain reached that level. That's an important feature to recognize whenever we're looking at the kinetics of our drugs. The best we can look at with an agent monitor is what the patient is exhaling. And it will, in general, predict what will happen to the brain 3 minutes from that point. Thank you very much. Anyone can use GasMan to answer clinical and theoretical questions, and I hope that some of you do. It can be downloaded free from the internet.